Poststreptococcal glomerulonephritis in children is my today's topic for discussion. The content include introduction, pathogenesis and pathology, clinical presentation, laboratory finding, differential diagnosis, treatment and the course outcome of poststreptococcal glomerulonephritis. As an introduction, poststreptococcal glomerulonephritis is caused by prior infection with nephrogenic strains of group A beta hemolytic streptococcus or strep pathogens. It is the most common cause of acute nephritis in children globally. The annual incidence ranges from 10 to 28 per 100,000 individuals, and the most common age is in children between 5 to 12 years of age. Poststreptococcal glomerulonephritis appears to be caused by glomerular immune complex disease induced by specific nephrogenic strains of group A beta hemolytic streptococcus. The resulting glomerular immune complex disease triggers complement activation and inflammation. Most evidence suggests that the major pathogenic mechanism is in situ immune complex formation due to deposition of streptococcal nephrogenic antigens within the glomerulus. Light microscope shows a diffuse proliferative glomerulonephritis with prominent endocapillary proliferation and numerous neutrophils. And immune fluorescence microscope reveals a characteristic pattern of lumpy deposits of immunoglobulin and the complement on the glomerular basement membrane and in the mesangium. Electron microscope shows electron dense deposits or humps which are observed on the epithelial sides of the glomerular basement membrane. When we see the clinical manifestation, there is usually an antecedent history of group A streptococcus skin or throat infection. The latent period between group A streptococcal infection and the PSAGN is between 1 to 3 weeks following pharyngitis and between 3 to 6 weeks following group A streptococcal skin infection. The clinical presentation varies from asymptomatic microscopic hematuria to full-blown acute nephritic syndrome. Acute nephritic syndrome is characterized by red to brown urine, proteinuria, which is most of the time subnephrotic, but it can reach up to nephrotic range in 5%, edema, hypertension, and elevation in serum creatinine. The most common presenting signs in children are edema, which is present in 2/3 of patients, and the gross hematuria is present in 30 to 50% of patients, and hypertension presents in 50 to 90% of patients, and 10% will have hypertensive encephalopathy. Acute renal failure is also common. Subclinical cases of PSAGN are primarily characterized by microscopic hematuria, which was diagnosed or seen suddenly when a patient gives a urine for some other thing. Regarding laboratory findings, on urine analysis, hematuria with or without red blood cell casts and the nephrotic range proteinuria can occur in about 5% of cases at presentation. Low C3 level and a normal or only slightly decreased C4 level is there, and elevated titers of antibodies to streptococcal products is evidence of a recent group A streptococcal infection. A streptosium test which measures 5 different streptococcal antibodies is positive in 90 to 95% of patients, and ASO is more positive after group A streptococcal pharyngitis, whereas anti-DNase is more common after streptococcal skin infection. PSAGN is usually diagnosed based upon clinical finding of acute nephritis and the demonstration of recent group A streptococcal infection with low C3 and the normal C4. A biopsy is performed in whom other glomerular disorders are being considered. For example, presence of nephrotic range proteinuria, absence of evidence of streptococcal infection, normal complement levels, persistent hematuria, proteinuria, decreased renal function, and low C3 level more than 2 months after onset, recurrent episodes of hematuria, and a progressive increase in serum creatinine are indication to do biopsy. Membranoproliferative glomerulonephritis is one of the differential diagnoses. In this case, there is persistent nephritis and hypocomplementemia beyond 6 to 8 weeks. Whereas in PSAGN, they resolve and the complement level corrected after 6 to 8 weeks. IgA nephropathy, in this case, there is a short time between the antecedent illness and the hematuria and the history of pillar episodes of gross hematuria because it's recurrent. Secondary cause of glomerulonephritis, such as SLE, in this case, extrarenal manifestation of the underlying systemic disease and the laboratory testing should differentiate them from PSAGN. On management, most of the time management is supportive and it's focused on treating the complications. Fluid and salt restriction, diuretics, and management of hypertension with calcium channel antagonists, vasodilators, and ACE inhibitors are sometimes needed. But most of the time, salt restriction and the diuretics might be enough. A 10-day course of penicillin is recommended to limit the spread of the nephrogenic organisms, not to benefit the patient. It is just to limit the spread of the nephrogenic organism. Complete recovery occurs in more than 95% of children with PSAGN, and the diuresis typically begins within 1 week. And the serum creatinine, complement level, and hematuria usually resolves within 4 to 6 weeks. Proteinuria also falls during recovery, but at a much slower rate. Recurrences are extremely rare, and the chronic renal disease occurs in less than 2% of affected children. Thank you for watching.